Welcome to this explainer. We're dropping straight into a high-speed, high-yield pediatric and neonatal management drill, testing your pattern recognition and single-clue pivot skills to help you crush test day.
Section 1. Respiratory and Airway Traps. We're going to see how distinguishing between upper and lower airway clues dictates your very first intervention.
Here's your first case. A healthy newborn presents with cyanosis that significantly worsens during feeding, but oddly enough, it completely resolves when the baby cries. What's the most likely diagnosis? It's choanal atresia. Neonates are obligate nasal breathers, so crying actually opens up the airway. You don't want to fall for the congenital heart defect trap here. If it were a structural heart issue, the cyanosis absolutely would not improve with crying or with 100% oxygen.
Next up, a full-term infant born by C-section develops tachypnea. Take a look at the X-ray on screen. You'll notice bilateral, perihilar linear streaking and fluid right within the inner lobar fissure. What's the diagnosis here? Transient tachypnea of the newborn. That fluid in the fissure combined with a full-term C-section delivery is your crucial pivot point. Now, if this were a premature infant with ground glass opacities, then you'd be looking at neonatal respiratory distress syndrome instead.
Let's flip it. Now we have a premature neonate with severe respiratory distress. The X-ray reveals low lung volumes, prominent air bronchograms, and a diffuse ground glass appearance. What is the best next step? You need to administer continuous positive airway pressure and artificial surfactant. Surfactant deficiency with air bronchograms demands this active treatment. Avoid the trap of simple supportive care, as you'd reserve that exclusively for transient tachypnea of the newborn. A newborn shows up with severe distress and hypoxia. On exam, you note a scaphoid abdomen, and you actually hear bowel sounds in the left chest. Next step? Secure that airway immediately with endotracheal intubation. The scaphoid abdomen points directly to a congenital diaphragmatic hernia. Whatever you do, do not use bag valve mask ventilation here. It's disastrous. It might work for simple neonatal apnea, but here you just pump air into the herniated stomach and compress those lungs even further.
Try this one. A neonate has central cyanosis that fails to improve on 100% oxygen. What's the best next step? Administer prostaglandin E1. This is a classic, failed hyperoxia test, pointing straight to ductally dependent congenital heart disease. You literally must maintain ductus arteriosus patency right now. Indomethacin is the exact wrong move in this scenario, because you'd only use indomethacin to close a patent ductus in an older, non-cyanotic infant.
It's autumn, and a 2-year-old child presents with inspiratory stridor and a really distinct barking cough. What are we looking at? Croup or laryngotracheitis. That barking cough in a child under 3 years old is your primary giveaway. You can safely rule out epiglottitis because that child would look toxic, be drooling, have severe dysphagia, and would typically be sitting forward in a tripod posture.
Speaking of epiglottitis, what if an unvaccinated 4-year-old presents with sudden onset sore throat, drooling, severe dysphagia, and is in that exact tripod position? What is the most likely pathogen? Haemophilus influenzae. Being unvaccinated and drooling points right to it. Don't confuse this with RSV. RSV would be the answer if you had a fully vaccinated infant presenting with the wheezing and coughing typical of bronchiolitis.
Section 2. Hydration and GI management. Let's see how weight trends and feeding habits dictate aggressive versus conservative management.
A 2-month-old infant spits up formula after every single feed and is crossing percentiles downward on the growth chart. How do you manage this? Start proton pump inhibitors or use thickened feeds? Crossing percentiles down means failure to thrive. Shifting this straight to pathologic GERD. If the infant was just a happy spitter with perfectly adequate weight gain, then you'd offer positional therapy and reassurance.
A 5-day-old exclusively breastfed infant loses 11% of their birth weight. The parents also notice brick red crystals in the diaper. What's your move? Assess for breastfeeding complications and consider formula supplementation. The 11% weight loss plus those urate crystals screams significant dehydration and lactation failure. Simple reassurance is dangerous here. You would only reassure if the weight loss was strictly under 7% in those first 5 days. A post-term neonate is born unresponsive in severe respiratory distress and is surrounded by green amniotic fluid. Diagnosis? Meconium aspiration syndrome. The green fluid in a post-term baby makes this a pretty straightforward call. It is not persistent pulmonary hypertension of the newborn. That would feature clear fluid, structurally clear lungs on the X-ray, and severe cyanosis caused by a right-to-left shunt.
Section 3. Neonatal jaundice pathways.
The timing of presentation and the specific type of bilirubin completely change your management algorithm here.
An infant develops jaundice within 18 hours of birth. Labs show a positive Coombs test and elevated indirect bilirubin. What's the cause? Immune-mediated hemolysis, like ABO incompatibility. Jaundice under 24 hours plus a positive Coombs test means pathology, requiring rapid phototherapy. Physiologic jaundice wouldn't actually peak until day 3 or 4, and crucially, the Coombs test would be completely negative.
Now, a 4-day-old infant has jaundice, fewer wet diapers than expected, and a poor latch. Diagnosis: lactation failure jaundice. Suboptimal feeding and signs of dehydration in the first week of life are your classic identifiers here. Breast milk jaundice, on the other hand, shows up in an infant older than 1 week who is feeding perfectly well, fully hydrated, and gaining weight normally.
Despite phototherapy, an infant's unconjugated bilirubin rapidly climbs to 26 milligrams per deciliter. Next step, initiate an immediate exchange transfusion. A bilirubin level over 25 is a critical emergency to prevent neurologic dysfunction. Simply intensifying standard phototherapy just isn't enough anymore. You only stick to phototherapy if levels are safely below that neurotoxic threshold. A 4-week-old presents with jaundice, hepatomegaly, echoic stools, and dark urine. An ultrasound reveals an absent gallbladder. What surgery do they need? The Kasai procedure, also known as a hepatoportoenterostomy. Acolic stools and direct hyperbilirubinemia clearly indicate biliary atresia. Do not just offer reassurance here, as that's strictly reserved for isolated, mild, indirect hyperbilirubinemia.
Section 4. Infection and Neurology Drills. Let's test your empiric antibiotic choices and CSF analysis.
A 7-year-old child presents with a fever, tender anterior cervical lymphadenopathy, tonsillar exudates, and notably, no cough. Best next step? Perform a rapid strep test or administer empiric penicillin. Having all 4 Centaur criteria makes streptococcopharyngitis highly likely. Don't just send them home with supportive care unless they only have viral symptoms, like a prominent cough and conjunctivitis.
A child with known cystic fibrosis arrives with community-acquired pneumonia. What specific pathogen must you cover empirically? MRSA, typically with IV vancomycin. That CF diagnosis changes the entire antibiotic profile. Standard amoxicillin monotherapy absolutely won't cut it here. You'd say that for a typical mild pneumonia in a healthy school-age kid.
A 2-week-old infant exhibits temperature instability, lethargy, poor feeding, and a bulging fontanelle. What is the most common cause? Group B Streptococcus. Being under 3 months old makes GBS the top suspect for neonatal meningitis. Neisseria meningitis or strep pneumo become the primary culprits only for older children between 3 months and 10 years of age.
A 2-year-old has a 5-minute generalized seizure during a 102-degree fever, but in the ER she is completely back to her baseline mental status. Next step? Supportive care, like acetaminophen. A rapid return to baseline and a seizure lasting under 15 minutes defines a simple febrile seizure. There's no need to rush to a lumbar puncture and IV antibiotics unless she had a prolonged post-ictal state or signs like nuchal rigidity.
Section 5. The 60-second final checklist. Let's lock this in with a rapid-fire rundown of the ultimate test day pivots you have to memorize.
Review your age cutoffs immediately. Any neonate under 28 days with a fever gets a full workup and empiric antibiotics. Remember your airway first priorities. Drooling in a tripod posture means epiglottitis and airway control first. Differentiate your bilirubin. Jaundice under 24 hours or direct hyperbilirubinemia is pathologic and requires an immediate workup, whereas indirect after day 2 might just be feeding related. Know your weight loss thresholds. Up to a 7% weight loss in the first week is completely normal, but beyond 10% requires intervention. And finally, know exactly when to pivot from supportive care to emergency interventions. An O2 sat failing to improve on 100% oxygen requires prostaglandin E1, and a febrile seizure lasting over 15 minutes demands a meningitis workup. Keep these pivots sharp, master these clues, and you'll easily control the exam.